So the committee wanted to better understand how counties are claiming EPSDT funds for KDA services. And counties provide intensive care coordination and intensive home-based services and claim federal reimbursement through what we call the Short Doyle Medi-Cal claiming system. And that is the same process for billing all other specialty mental health services. Currently, there are 44 counties who are providing and submitting claims for these services. There are 12 counties who have the ability to process claims for these services, but are not yet providing the services. And there are 2 counties who do not yet have the ability to process claims for these services and are not yet providing the services. But every month we're seeing an increase in the number of counties that are able to claim for ICC and IHBS. We're seeing a number of the number of subclass members that are actually being served increase. We're seeing the dollar amount for these services increase, and also the services themselves are increasing.
So in other words, the counties that are not up and operating yet, these services are just not available?
Those counties who are not yet up and operating their claiming system, they are in the process of readying their processes, their systems, putting teams in place, doing the training, identifying the subclass. So they are doing all the readiness, preparedness. And there are a few counties who are actually providing the services who cannot yet claim for them, but they still are providing them, awaiting for their system to be able to claim, and then they will claim for those services.
Okay, thank you very much.
The other question that the committee had asked is communications with the Centers for Medicare and Medicaid Services regarding therapeutic foster care. The department submitted a state plan amendment on March 28th to the Centers for Medicare and Medicaid Services, and we continue to work with CMS through the SPA process to determine if, in fact, whether or to what extent a SPA is needed for therapeutic foster care services, and to answer any questions CMS may have. Our most recent communication with CMS, we had a teleconference with them on April 18th.
All right, thank you very much. Senator Martin?
When you describe therapeutic foster care, can you just give an example? Is that a home placement that has special training or skill in dealing with mental health issues?
Yes, it is. The therapeutic foster care model that we're contemplating is one in which the foster parent is both the caregiver and among the primary kind of change agents, if you will, for the youth, and it requires a substantial type of amount of training and a substantial level of support from an agency also to kind of coach and mentor the foster parent. And
can it be an existing foster parent who has a foster child who this evaluation is made? Can that current foster parent be trained or be given the tools to be that change agent, or does it require a transfer of the child to a facility that's equipped?
Yeah, potentially some of the existing foster parents that are serving young people now would likely be able to make that transition. We do have a number. We have some intensive treatment foster care programs and some other very intensive foster care programs that are available currently. Some of those folks should be able to make the transition. I mean, the part of the model contemplates a very small a placement of 1 or 2 young people and a lot of guidance and support from the foster parent. So it doesn't necessarily mean that a foster youth in a kind of a stable placement would need to change. The question would be, does that that youth meet the criteria for therapeutic foster care in a placement that's relatively stable now? I think so. There'll be some of those implementation challenges are still in front of us.
So it sounds like there needs to be an evaluation made at the time there's the evaluation of the child. You mentioned one of the challenges was lack of providers. In our materials, I saw kind of a universal figure for Los Angeles County of about 100,000 clients up to age 21. Do you have any estimate of statewide? What's the universe of foster children or the percentage of foster children for whom these more specialized services are needed?
The original estimate of the subclass so the subclass is determined as a youth that's in a group home now at imminent risk of placement in a high-level group home, in a psychiatric facility or some similar situation, or who's had 3 or more placement changes in 24 months related to behavioral issues. Those numbers through our administrative database aren't entirely knowable, and so the process we're going through with the counties now is to actually, physically identify all those young people. The estimate was roughly 10 to 11,000 as I recall.
Mm-hmm. Yeah, that's helpful. I'm just trying to get a sense. And then it sounds like there's clearly an overlap between behavioral problems and mental health diagnoses.
Yeah, the intent is not to pathologize youth in order to get the comprehensive home-based community-oriented services.
Thank you.
I wanted to go back to the EPSDT funds again. Is there anything that can be done to ensure that some of these counties are maybe starting to move forward and get their programs online? Is there anything?
Yes. EPSDT services are entitlement services,
Yes.
and all counties know that they are an entitlement service and must be provided. And as Mr. Rose had described, the launch and really getting the systems together and ready, we do work with the counties and provide technical assistance and have constant communication with those who are not yet up and going with claiming to see how we can help and to determine what is their action plan for when they are being able to will be able to claim for the services and be ready. And we're very encouraged by our communications and what we're hearing from the counties. Some it's just a matter of a very short time. They're well on their way. So we are encouraged with what we're hearing and the technical assistance and communications with the counties.
Okay, good. That's good to hear. Thank you very much.
You're welcome.
All right. Department of Finance, any questions? Legislative analysts, any comments? All right, thank you. Public comment on these items? Please come forward. Hello?
Thank you for your help. Good morning. My name is Farah McDade-Ting from the California State Association of Counties. I want to thank you for the overview and hearing this issue. As a representative of the counties, I'd like to provide a little bit of background. We are in the midst, as staff indicated, in launching the KDA services within counties, and as was noted in the background as well, we're sort of on a staggered process with which services are being offered. We have this potential state plan amendment for the therapeutic foster care that's still in progress. So until we get that figured out with the federal government, it's harder for counties to provide that service yet. I'll also note that the KDA settlement occurred after the 2011 realignment, and in 2011 realignment, child welfare services and children's mental health services were realigned to the county. So this is a post-2011 realignment sort of issue and program. So these are some of them are newer services. So we're working with the administration, the Department of Finance, the other departments, as well as the legislature, to figure out a way that we can make sure that the funding is aligned with the new services that need to be provided. As they indicated, the counties are sort of all over the map on how they've been implementing. We've been very, very, very emphatically reminding them that it's an entitlement service, and that you need, if you have children that are part of this subclass, that you need to provide these services. So we've been working within our county family on those issues, and we've seen great progress there. So I just wanted to give a little background and let you know where the counties were. Thank you very much.
Thank you very much. That's very much appreciated. Thank you for your comments. All right. We can go on to the next item, which is continuum of care and the update. And welcome again, Mr. Rose.
Thank you, Madam Chair, members. As the background paper or the agenda describes, the continuum of care has its origins in the legislative process, and happy to talk with you a bit about where we are today. Just to think about some of the information that's been guiding the thinking about the continuum of care reform is that the work's really guided by the philosophy that children and youth should grow up in families, that relative caregivers and foster parents might require timely services and support to sustain healthy development of young children in their care, and that as Director Lightbourne mentioned earlier, that interventions that require non-family settings need to be short-term and intensive. Where we are at the moment is I'll spare you the details of all the various work groups in terms of the mechanics of the work groups, and describe a little bit about what we're hearing from each of them. Just to remind you that the work groups had been ongoing for many months, a program work group, a fiscal work group, and an outcomes work group. Those recommendations from the work groups then come to the department. The department considers those recommendations and ultimately authors a report to the legislature with our best thinking informed by that work group process about how to move forward with the continuum of care reform. That said, a couple of the things that we're hearing from the work groups, in the program work group, there's been a lot of, they've ratified, if you will, that the interest in, congregate care should be short-term, intensive, treatment-oriented. There's some recommendations that about a set of core services that any kind of congregate care provider should offer that focus on serving young people. Serving young people in some of the well-being domains, if you will, and really working towards discharge from the facility from day one. The other things that we're hearing from some of the program work groups is some thoughts about provider qualifications. If we want short-term intensive treatment environments, what kind of staff and staff qualifications are needed, and what breadth of staff do we need? A mix of professionals and a mix of folks that have life experiences that are important to serve young people, even in that short-term time frame. The fiscal work group has really been looking at how do you fund such a system, and thinking about a rate for congregate care that is adequate to meet those treatment needs, and also has been thinking about and working towards understanding how to braid and blend other service system funding to support the services and supports that we just described in KDA. So, for instance, there's an interest for those youth who have medically necessary mental health needs that EPSDT could be part of a package that would support young people to be served in the community in family-based environments. the performance and outcomes group has really thought about how do we recognize quality providers, and how do we make those data and that information publicly available. And it includes a recommendation to do a youth satisfaction survey so that we get feedback from youth, not just administrative data and our licensing database, for instance.
That's a good idea.
So the other question you had is, well, you know, what are we going to see in the report? I think, and what I'd like to say about that is we're contemplating the things that I just described. So in the report that comes to the legislature in October 2014, clearly there'll be recommendations on policies and practices to support youth in families, in communities. There'll be a fiscal structure that aligns with that goal, that would include thinking about how the reliance that child welfare has on other service system funding and supports, whether it's physical health, mental health, education, or what have you. And we'll certainly be looking at, in essence, some kind of publicly available data, as I described. And then there'll be a rollout strategy that we'll present you with, so that we can talk about how do we, you know, transform the system in the way that Director Lightbourne described earlier in the hearing. The next question really had to do with KDA. So have we been thinking about KDA and CCR together? And I would hope that by now, the way we've described the kind of goals and aspirations and design and recommendations, frankly, that we've gotten from the work groups relative to the continuum of care reform, you'd recognize that those goals, philosophy, practices, and orientation are consistent with KDA. In my head, you really can't separate the two. The kinds of services and supports that are contemplated in the CCR work are in part, but not in total, ICC and IHBS and TFC, but others as well. So they really are aligned, and in some ways, one of the parts of one of the things we've been talking about with KDA kind of on a go-forward basis is part of our strategy is ultimately to debrand KDA and have KDA, its core practice model and services become the new normal. And certainly the CCR work helps us, it provides a potential vehicle for that transformation and that kind of new normal and the post-jurisdictional kind of phase of KDA. So we see them incredibly aligned, and hope you do too.
Yes.
I would just say, since my colleagues from Healthcare Services are sitting next to me, they're members of our executive committee, along with county agencies and probation departments, and have been working with us on a number of the technical aspects that I described earlier.
Okay. Thank you. And you are going to answer the question about what characteristics would be appropriate to refer a child or youth to a group home care in contrast to family-based settings?
Yes.
Okay.
Just about.
Thank you.
Just about to do that. We had a little tease of that in an earlier exchange with Senator Monning. But what I would say around which characteristics, I think so. A couple of things that are important to note. Certainly, whatever placement a youth is in, a child or a youth is in, especially if it's a congregate care facility, the program goals and the program needs to meet the needs that youth has. We talked briefly a moment ago about the juvenile justice population and some of their unique needs. One thing to note along the juvenile justice population, for instance, is that there has been some success in the literature around with sexual offenders and the benefit of a structured environment like a group home, for instance. When you think about other characteristics that young people might have that would indicate at least a short-term stay in a group home, could we think about mental health crises, other behavioral issues, and potentially substance abuse? Again, our thoughts around these are in the new way of thinking around the system would be, even those situations you'd have youth in care for relative short periods of time, and then transition towards the community. Second part of the question was what you asked about policy recommendations that can support intensive services in family-based settings. We've talked about a number of them up to this point, but if it might bear identifying a couple of others. One of the things that's very important to get the kind of the right service at the right time, the right youth in the right setting, has to do with providing the planning for the evaluation of and the thinking about service delivery in a child and family team process, so that there's consumer voice and choice. Folks that are important to that family also play a role, along with the system players. So it's a team-based kind of case planning process that results in comprehensive and tailored services. It's probably important to reiterate that the service array and supports need to be available, and they need to be available timely, and it does speak to the notion of looking at the alignment, the program and funding alignment of the other types of services and supports that serve youth and families in the community, some of which I've mentioned earlier. And so I think those are a handful of the policy things that are potentially worth considering.
Thank you very much. Any questions, Senator Monning? Department of Finance, Legislative Analyst. All right. Well, thank you very much for that portion of the agenda. We're going to excuse you for a moment, and also Department of Finance and LAO, so that we have room for all of our panelists who will now come forward. We have several great panelists who will be joining us this afternoon. It is this afternoon now. Jennifer Rodriguez, Executive Director of the Youth Law Center. Frank Mecca, Executive Director, County Welfare Directors Association. Gail Johnson-Vaughn, Mission Focused Solutions. Brian Blaylock, Bingham McCutcheon Youth Justice Attorney, Bay Area Legal Aid. Carol Schroeder, Executive Director, California Alliance of Child and Family Services. Vanessa Hernandez, Policy Coordinator and California Youth Connection, and Kyle Sporletter, Legislative Coordinator, California Youth Connection. Have we forgotten anybody? Is everybody here? All right. Thank you all very much. Appreciate you here. Appreciate you being here to share your expertise.
Thank you, Madam Chair and members.
And please push that red button. Thank you.
Thank you, Madam Chair and members. My name is Jennifer Rodriguez, and I'm the Executive Director of the Youth Law Center in San Francisco. And we're a national advocacy organization for youth in the child welfare and juvenile justice system. And really the core focus of our work is to address and to improve the conditions that children in foster care in the juvenile justice system live in. I wanted to actually start just by weighing in on your question about the characteristics of children who need a group care setting. And I think the answer is not so much that I don't think there is a characteristic of a child. I think the answer to that question is the only time a child should be in a group care setting is when there are services that can be provided to them that could not be provided in a family setting. And I know I'm still not clear. I feel like I've been here every year saying I'm not clear exactly what those services are that we can't provide in a family setting, that we have to institutionalize a child for, but I think that's probably the most accurate answer to that question. And along those lines, over the last 2 years, we've been working with the support of the Annie E. Casey Foundation to convene a group of the most talented researchers, both nationally and internationally, to study what the developmental impacts of group care are on children in foster care, because we know some about the outcomes. We certainly know the anecdotal stories, but we didn't have a lot of data about the developmental impacts. And the researchers have come up with a conclusion, which will be published and put out there sort of to the general public very soon. But basically, they have found that even for the very best congregate care setting, that those settings can be developmentally damaging, and they must be used only as an emergency short-term treatment that for a service that cannot be provided in a family setting. And so that's very much aligned with the policy direction that the continuum of care effort has taken and that the legislature has supported. The good news in that sounds sort of absolute, is that we do know what works. The researchers are also coming out with a very clear statement that from a developmental perspective, stable long-term parenting relationships, those are the panacea for young people who are in foster care. And children who lack these relationships and the protections they provide, we know the developmental researchers will substantiate they face lifelong occupational, educational, interpersonal challenges. And in my opinion, one of the most significant ones of those is challenges parenting their own children. And I did also want to respond to the question about probation youth, and that's that the research also really supports that the only intervention that we've seen promise in for youth who are in the probation system is multidimensional treatment foster care, which is a model where a foster parent does a treatment almost like intensive foster care. So again, not a residential institutional model at all. As you can see from the data that CDSS provides us, we do have more than 6,000 children that we're still currently subjecting to those risks and potential long-term damage. And in that group, nearly 3,000 of those young people we've been subjecting for more than 12 months, which I think to us adults, it sounds like a relatively short period of time, one legislative session. But for children who are growing up in their very, very short lives, it's a significant amount of time to be growing up without parents, without the consistency and stability that being in a family provides. Some of the recommendations that we hope to see come out of the continuum of care reform process are we feel strongly that we have a need for ongoing and regular review of children and youth who have been in group care for 12 months or longer, and that there needs to be a targeted and specific plan developed for each and every one of those children for moving them out into families. We do know some tools that will get us there. We've been working with CWDA and CDSS for the last 4 or 5 years on the Quality Parenting Initiative, which is an effort where we're working with 20 counties to improve their capacity to recruit and retrain foster parents. You have budget proposals in front of you today that do things like fund a permanency pilot to get children into families, that will expand funding for relative caregivers, that will provide desperately needed services for youth who have experienced sexual exploitation, who really need to be in a family to heal, but are going to need a lot of services in order to be successful in a family. We also know that we need support for youth and families when youth do transition out of a group home and into a family. I mean, I can say personally, I remember how challenging it was for me, having grown up in group care, to learn anything about living in a family. For a very long time, I was actually intimidated of families and talking to adults, period. And all of the little skills that you take for granted growing up in a family, I believe, like how to resolve conflict appropriately, how to communicate, how to receive and express affection, how to cope with stability, which sounds odd, but it is actually a challenge when you've grown up in group care. Those will all be challenges that those young people will face, and that the families will need an incredible amount of support in also getting through. We would also like to see an emphasis really on the program. Going back to that core question you asked, we want to know what these group care facilities are going to be providing that a family cannot provide. We want close scrutiny of that and monitoring of that. And then fourth, we would like to see improved accountability to community care licensing. They are the only entity in the state that has the ability to go into a home and find out what's happening and issue a citation or get a facility shut down. We currently are in a sort of a structure where a group home may only be visited once every 7 years, which does not seem like a good accountability structure in the least bit. We'd like to see some additional protections in place, such as when a facility has had an inappropriate number of complaints or calls to law enforcement limiting further admissions for young people to come into the home. We also would like to see other use of resources. I think in a perfect world, I would love to see something happen like before we ever made the decision to place a young person in a group care environment, that we would spend an equivalent amount of resources doing intensive family finding work for that young person before we made the decision that we had to deprive them of parenting. We believe, as I think the legislature and CDSS and CWDA believes, that we have the ability and we also have the obligation to every child in the system to find them a family and find permanence. And we also think we know what works. And And so we're really hoping to see a policy structure and some resources follow that. Thank you.
Thank you very much for your presentation. Mr. Mecca.
Thank you, Madam Chair. Frank Mecca, Executive Director of the County Welfare Directors Association, and we're part of a coalition sponsoring 2 budget proposals that we believe are essential to achieving the goals that you've talked about so far this morning. One speaks directly to the really excellent and always excellent testimony of Ms. Rodriguez,
Yes.
and it's about the backbone of our foster care system, families. We're requesting $6.75 million general fund to invest in families and relative caregivers. Virtually everything that we've talked about this morning really relies on our ability to recruit and retain families. KDA implementation, the CCR, rolling out therapeutic foster care, reducing our reliance on congregate care, increasing permanency, all of it rests on our ability to find families, high-quality families, who can meet the needs of children. We expect so much from these families, and we provide them with so little by way of support. It's no surprise that they often feel frustrated and overwhelmed. As you know, the Child Welfare Program was realigned in 2011, and the program, that's about a $2 billion program overall in state resources, dedicated $1.9 million to recruitment and retention of foster parents and relatives, the backbone of our system. As a result, we've had a very, very difficult time recruiting and retaining an adequate supply of high-quality foster families. Since 2003, the population of children in the foster care system has dropped by about 40%. We've lost 50% of the licensed foster care bed capacity in counties. Our proposal, which I won't go into detail, it's been provided to the committee, would provide a long overdue investment and support for foster parents and relatives. For example, it will enable counties to staff warm lines for foster parents, somebody to answer the phone when there's a crisis, mentors for new caregivers, increased training and respite care, which are essential. We could also use the funds to target recruitment efforts so that we have a deep and broad pool of foster parents, and so that we could target some specialized foster parents. For example, we're desperate for families that can take sibling groups, families that can meet the needs of LGBTQ youth in their homes. Lastly, foster parents need resources with assistance for expenses like academic activities or sports activities, the type of activities that allow a foster youth to feel normal, like everybody else, but they're very expensive. The proposal is modest, but we think it really gets to the essence of everything we've talked about this morning, and we appreciate all of your consideration of that proposal.
Absolutely. Thank you.
We have one more proposal that is certainly in line with everything we've discussed so far already. We're part of a coalition that's sponsoring a budget request to build a capacity for child welfare agencies and our partners to serve child victims of commercial sexual exploitation, which is known by the acronym CSEC. It's too antiseptic for the horror that it actually is. California has 3 of the top 3 cities in the nation, including Oakland and Los Angeles, with the highest incidence of sex trafficking. The average age when these children, both boys and girls, are lured by pimps is 12 to 14 years old. Some are even younger. Many have had prior involvement with the child welfare system, and that's a shame. Most are recruited after running away from their prior homes, including group homes. And we've learned more about the issue. It's become clear to us that these youth who have endured such extreme trauma and abuse, something has to be done immediately to help build a capacity to serve them. Yet this really is an epidemic that's beyond the capacity of the traditional child welfare system. These are not youth that are abused in their homes by their caretakers. We need a profound shift in the way we help and support these youth. A few counties like Los Angeles and Alameda have patched together some resources. Most of the counties, frankly, struggle with meeting the needs of these victims. Our very modest proposal creates building blocks that we hope to be a multi-year effort to develop a robust system to serve CSEC victims. It would focus resources very briefly in 3 areas. The first is training. Social workers, foster parents, and youth themselves to identify and know how to intervene when a youth is being horribly exploited. The second is intervention. We can take a lead role to identify and assess the need for services, but we need partners, mental health, public health, probation, education, survivor groups, who are often the best groups able to help us. And the third is services. To meet CSEC victims, get them to shelter, ensure basic needs, help them recover. Our traditional foster care system isn't equipped. We foster parents often, for example, fear pimps coming to their homes and retaliating. CSEC victims need support from other survivors. We need help with intervention to try to provide the support that would prevent or keep victims from wanting to run away. And they need intensive treatment to recover from a type of trauma that's hard for any of us to even fathom. This is a crisis that can't wait. We believe that the proposal on the table is sound and sensible and will allow us to begin the process of building the capacity in a system that's going to take years to deal with this horrible tragedy, and we appreciate your consideration of this proposal as well.
Thank you very much.